Thank you for joining us for Day 2 of Mayor Bowser's National Maternal and Infant Health Summit. Today we'll hear from various community partners for our virtual sessions. Presentations for Session A include Delivering Respectful and Anti-Racist Maternal Care, a multidisciplinary discussion, presented by MedStar Health. Supporting Breastfeeding in the Capital, the Role of Identity, Norms, Systemic Racism, and Resistance, presented by the DC Breastfeeding Coalition. More Than Safe Sleep, Children's National Hospital Primary Care Infant Mortality Risk Identification, presented by Children's National. Improving Maternal and Infant Health through the DC Perinatal Quality Collaborative, presented by the DC Hospital Association. We aim to rectify self-advocacy as a solution to maternal health crises, presented by Mama Toto Village.
SIDS affects infants less than a year old, with ages up to 4 months being particularly vulnerable. If the baby is sleeping in the bed with someone else, it increases the risk for SIDS or accidental suffocation. Now they can sleep in the same room with someone else beside the bed, just not in the bed. Nothing else in the sleep area. Remove all play items and soft objects from the crib at sleep time, and that includes bumper pads. Place baby on a firm, safety-approved crib mattress. Avoid overdressing your baby or setting the thermostat too high. And when it comes to sleeping, always, always, always place baby on his or her back. And get some rest, because you're gonna need it.
You don't know me. Probably never will.
But I need you to do something for me.
Something that could literally
change everything.
You'll never get a thank you card, and yet I need you to do it.
And if that weren't enough, I need you to do it as soon as you are able to.
If you do this for me,
I'll do it for you.
And for every single person you love.
Deal?
This is our shot to leave COVID behind.
Us and taking the time to listen to our panel discussion on delivering respectful care and anti-racist maternal care. Today's panel, we're not going to have slides. We really want to talk and have a discussion as much as we can in this virtual setting. We're going to start off with a viewpoint and information from an individual and a bedside healthcare delivery point of view. And then we're going to talk about the point of view around delivering respectful and anti-racist care from a group perspective in terms of a healthcare group, whether it's a midwifery group, a physician group. And then we're going to talk about what an organization or a hospital's department in OBGYN may do, can do, and should do in order to deliver the right care. And then we're also going to have comments about what can a large healthcare organization do to ensure that all of their areas are delivering respectful anti-racist care. We're going to talk individually, each of us, with our different and unique perspectives, and then we'd like to open it up for questions and discussion. So we hope this is informative and hope that after our discussions, it can truly be as interactive as possible. So with that, I'm going to turn it over to Lily, and she's going to get started.
Thank you. Thanks, everybody, for having us and for organizing and for attending. I think you'll find that we're all really, really energized about what we do. And I'm really excited to be doing this work and to be sharing this panel with people who are doing some really impressive work in this field. So I'm going to get started. So my name is actually Libertad Montoya. I came to this country from Peru as a young person with my mother. Neither one of us spoke English, and together we learned to navigate this new country and its systems. I eventually had the great fortune of working with an ESOL teacher who figured out that I was curious and inquisitive, and she tailored her teaching to my learning style. I was my mother's translator, even though I was just learning the language myself. I translated in the grocery store, at school, and in the doctor's office. My mom couldn't help me with my schoolwork, so one day when I asked her for help with the projects, she suggested that we ask someone smart that we could trust. Renee Poussin from WJLA TV7. She was a photojournalist for any of you who are from DC. To be clear, we did not know her. I think my mom just figured she kind of looks like she could be related to us, and she's smart and probably nice. So I called up Channel 7 on the phone and I asked to speak to Ms. Poussin, and to my delight, they put her on the phone. She took the time to talk to me and to explain to me and things that I could understand. And then she thanked me for calling and for asking the question. She thanked me for asking questions. I learned at that moment that trust can be built very quickly, and that a seemingly fleeting moment can make a great impact on your life and how you feel and in how you see yourself. The same is probably true for the people that we serve as clinicians. Our patients remember not only how we help them to heal, but how we make them feel. So how do we deliver respectful and anti-racist birth care? We do it with a spirit of inquiry, humility, and empathy. Besides being a frontline clinician, I'm also nursing faculty, and I was lecturing at the nursing school when one of the students raised their hand and asked, Ms. Montoya, you really love what you do, huh? And I was like, yeah, you can't tear me away from bedside care. I think it's so important. So Ms. Montoya, how'd you change careers to do this? Essentially asking me what my origin story is in obstetrics. So I'll tell you, a few years back, some of my friends started having babies. And when I asked them what their experience was like, they all responded with the likes of, well, it was kind of weird. Stuff happened around me, but it wasn't about me. I was scared and no one told me what they were doing, or I don't feel like anyone listened to me. I had up until that point framed reproductive freedom as if or whether someone had a baby, but now I see that a major piece of this is also how. How do we do this? I'd never really given it a thought. I'd barely even set foot in a hospital for that matter, but not being seen or listened to or heard didn't seem right to me, particularly in such an intimate context. I mean, what's more intimate than how we have our children? I mean, pregnancy and birth are not inherently a sick state, right? It's kind of the original thing. We've been having children since well before anything. Ari Up proclaimed, in the beginning there was rhythm. I'll take that and give it an obstetric spin and say, in the beginning there was birth. So what I had thought birth must be like, about the birthing person at the very least, right? It was so strange to hear that it wasn't. So I decided to become a part of fixing that. I went to nursing school so that I could understand the healthcare system and how it worked. I learned pretty quickly that the people who spend the most time with the patients, who have the most contact, the greatest chance for direct action, are the bedside nurses. It's the people at the bedside that translate medical jargon to language that is accessible and relevant to people. It is the nurse clinician at the bedside who advocates for the team to deliver consent-based trauma-informed care. It is the bedside nurses that can identify ways to facilitate fetal rotation and descent to prevent an unnecessary C-section. It is the bedside nurse who is monitoring trends and brewing emergencies and escalates them to enact swift intervention before those findings lead to deleterious effects on the person. We work as part of a collaborative interdisciplinary team and practice for obstetric emergencies. In fact, our colleague, Dr. Auguste, created a simulation training that travels to MedStar OB units to provide ongoing education in that vein. That training is premised on the concept that communication is critical to enhance patient outcomes. So how do we deliver respectful and anti-racist care? Communication with the entire team. And the patient is the most important member of that team. They must be involved in their plan of care, in the best of circumstances and in the worst. I collect old medical nursing textbooks, and I was leafing through the 1933 edition of Obstetrics for Nurses and found that they were concerned with placenta previa, preeclampsia, threatened rupture of the uterus, and other emergencies. Those concepts haven't changed, but there are many concepts that have existed for years that we do not adequately acknowledge or address, and that time is over. I imagine that we don't need to do a lot of level setting here today, as we are likely ideologically aligned and are thus coalescing around common goals, which include delivering respectful and anti-racist birth care. And how do we accomplish this? In healthcare, we borrow quite a bit of training from the aviation industry. As a matter of fact, Patricia Benner's work on how nurses acquire knowledge is partly based on a training model for Air Force pilots. To that end, I've developed a tactical plan for us to start tackling this issue. So number one, we need to start before the bedside. We should not introduce anti-racist training when people are hired and start working at the bedside. It is too late of a start. They should have heard of this well before they interact with the public as healthcare clinicians. As faculty, I support concept-based education. The increasing complexity of patient care and the quickly changing healthcare landscape necessitates that we shift the way we think at the bedside, and more importantly, how we train our future colleagues to do so. Our work requires knowledge, skills, and higher ordered thinking. We are experiential learners. We synthesize what we learn and apply it to future encounters. We must train our future colleagues to think and apply knowledge in the context of specific situations so that they may grow and manage other tricky situations. What that means is that in professional schools, we should teach the concepts of infection, pain, perfusion, safety. Then we apply those to obstetrics when we specialize. To those concepts, I'd like to add trauma as a concept to be taught. And I don't just mean trauma-informed care in the traditional sense, trauma related to sexual, physical, or emotional abuse, though that should also be a part of our teaching, and we do not sufficiently address it at this time. But what I am talking about is the trauma that we carry as a result of racism. Our bodies are meant to exist in a state of balance. We call it homeostasis when we try to be fancy. When that balance is thrown off, we compensate through a variety of biological processes to get us back to equilibrium. We have protective mechanisms built in to protect us from those threats. One of those is fight or flight, right? Fight or flight is meant to be a temporary way of getting through a dangerous situation. When this state is prolonged because the threats are all around us, all the time, all over, from potentially all directions, and that stress response, which is a tool designed for our survival, is now slowly wearing us out. Geronimus and colleagues tell us that that stress is weathering some of us so that the very thing meant to help us to survive is now killing some of us. The bias literature tells us that it's not just bias, but the anticipation of bias that can also contribute to this effect. So how do we deliver respectful and anti-racist care? We need to train our future colleagues about this concept before they see a patient so that they can understand how this works, just as they will understand how infection works and how pain works and how oxygenation works. We need to embed this into our curricula so that anti-racist training isn't just another box to check, another task to complete and forget, but a basic concept as important as being able to breathe. We need to train our future colleagues so that they can understand the grave responsibility of the legacy of racism on the health of the public. And that includes the health of people who give birth. I want to acknowledge right now that not all people who give birth identify as women, but we are all people who need to be served by anti-racist and respectful care. Number two, we need to continue at the bedside. Bernice Johnston Regan said that the thing that must survive us is not just the record of our practice, but the principles that are the basis of our practice. It is not enough to be culturally competent and deliver care that is not racist. We must actively, intentionally, and perpetually interrogate our systems and continuously reflect on our practice, in our practice, to be specifically anti-racist, to disrupt the patterns and dismantle the systems that create, grow, and maintain inequity through lack of access, suboptimal care, and the bias that underpins it all. And this work challenges us to stretch in our reach because it must come from a stand of humility. We used to call it cultural tolerance, then cultural acceptance, then cultural competence. How many of us have completed myriad trainings with one of these titles? The thing is that tolerance and acceptance and competence all work on the presumption of power as the premise. Humility takes the power dynamic out of it. It says, I'm taking myself out of this and meeting you where you are. But humility is hard, right? It requires us to step outside of ourselves and strip back the cloaks that protect us, the cloaks that we think protect us. For clinicians, it might be our letters. There are a lot of letters on this panel today: OB, GYN, RN, CNM, PhD, MPH, MSN, MBA, IBCLC, OMG. One of our cloaks is privilege. How we construct, accept, and maintain frameworks of race, class, and gender. Humility begs us to see if, when, and how they intersect. Humility is an ongoing struggle. It asks us to look with a critical lens at what we think is our expertise and what we believe to be true and wonder, is it true? What is the basis of this knowledge? Is it still or was it ever valid? And how does knowledge change and grow? We deliver respectful and anti-racist care when we abandon cultural scripts that tell us that only certain people are at risk. Those cultural narratives permit us to create an image of who is at risk and let ourselves off the hook when we can, as a society, blame them for what happens to them. A few years ago, I floated to the ICU to care for a pregnant person who had a serious heart condition. When I got a report on the patient, the patient is difficult. I also got, well, she told me she's an architect. Why does she need to tell me that? What's she trying to do there? I heard from someone else, well, she has an attitude. I think we all know what that's code for. I got into the room and we built a rapport. I asked for her origin story, how she got to this moment. And then I just listened. She had called 911 several times because she felt like something was very wrong with her heart. Each time she was taken to a different hospital where she was not adequately informed about her plan of care, where her questions about her treatment and her medication were met with suspicion and derision from staff. She was discharged each time and sent home with no plan. At one hospital, the young woman who changed her sheets told her, "You know, they keep saying that you're mean, but you're not mean, you're so nice." Can you imagine how that made her feel? She got up and she thanked that young woman for validating her perceptions of being dismissed because they were not a figment of her imagination. They were true. She left that hospital and somehow ended up at Washington Hospital Center where we almost coded her twice on the cardiac unit. I was her nurse for several days and we conversed during that time about a lot of topics. She actively took notes about the patient teaching we provided, looked at her plan of care from different views, looked at how the different services, obstetrics, cardiac, neonatology, worked from different perspectives. She framed it out. She's an architect, remember? That's how she processes information. So I tailored my teaching to her learning style, and we developed a good working rapport. This is a person who knew something was wrong and was begging for healthcare. She was well-resourced and educated, and those things did not protect her because at many points the system did not listen to her. And many clinicians spoke in coded language to invalidate her voice, which served to create expectations that were then reinforced. Eventually, the medical system managed to do right by this woman, and she had the appropriate cardiac procedure. She gave birth to her daughter a few months later to go home alive to her partner and other children. So how do we deliver respectful and anti-racist care? We need to train ourselves and our colleagues to approach healthcare from a purposeful anti-racist stance. We must understand and recognize that there is research that disrupts our notions that only women who are Black and under-resourced have bad outcomes. In fact, there's research that points out that it is women who are Black and well-resourced who fare the worst in the healthcare landscape, who have the worst outcomes, like the woman I just mentioned. Delivering care that is respectful and anti-racist means that we recognize and understand where and how the intersections of identity inform the lives that we are allowed to lead and the care that some of us receive. It means that we must think about how we got here, what we are doing, and where we are going beyond the bedside. So number 3, when we go beyond the bedside, we need to consider and recognize that the work that we do at the bedside is not only the work of that specific encounter with that specific person, but that we must also set them up for success beyond the walls of our institutions. A young woman arrived by ambulance from a clinic. She was in her early 20s, had a history of bipolar disorder, suicide attempts in her childhood and early teens, and presented to our hospital with a fetal death. It became very clear to me that she was likely a survivor of sexual assault. Her initial encounters with agents of healthcare involved having several clinicians surround her bed, standing and crowding over her. They were doing typical healthcare stuff, placing an IV, taking up blood pressure, checking her cervix. She responded with panic and fear. Someone suggested calling psych. What was that like for her, do you imagine? We gathered as a team and we quickly revised our strategy and made a decision to deliver trauma-informed care. She was able to place her own blood pressure cuff, press the button when she was ready for it to squeeze her arm. She swabbed herself for COVID with specific directions. She placed her own speculum. She eventually gave birth to her baby and, consistent with what we know about bereavement care, spent time processing the loss. We were determined to help her change her story, to be part of at least one encounter where she had some agency over her body. We worked to provide space where she could process this devastating event and to help her to begin to heal. We worked to give her some of the building blocks of respectful care, where she was a participant in the process and not the victim. We made a specific and concerted decision to deliver care in a way that was respectful and not premised in a racist lens, because we knew that how we managed this event could impact her for years after she left our care. So how do we deliver care that is respectful and anti-racist? How do we do this work? We must identify and admit that racism, the act of racism, not race, but racism, is the problem. How does this play out for us? We get in jobs in healthcare, we are taught a dark legacy of things. We need to unlearn those things. We convey respect by acknowledging the fact that racism in our society that is a real fact, and by actively working to decenter cultural narratives of exclusion in order to change systems. Discussions about no prenatal care that serve to victim blame and obscure the mechanisms that underserve and under-resourced people. Pernicious myths about who feels pain and whose pain should be treated. Erroneous beliefs about how quickly some of us push our babies out that lead to interventions when we don't fulfill those expectations. The time to unlearn this all is long overdue. So how do we deliver respectful and anti-racist birth care? We must acknowledge that racism and its mechanisms and its structures and its systems exist. And then we must acknowledge that we must dismantle it. And then we must rebuild together as an interdisciplinary collaborative team, not in silos, but in partnership with the people that we serve. I want to thank you for letting me start this off today. And I'm really, really excited to hear what everyone else has to say. Thank you very much.
Thank you, Lily. I'm going to turn it over to Loral next to give her point of view from a group practice. Loral.
Thank you, Tamika, and thanks so much, Lily. I always appreciate opportunities to listen and learn with you. Good morning, everyone, and I want to kind of tailor my comments a little bit this morning to focus on sort of the work as an individual provider, as well as one of the hats that I'm privileged to wear in my work is with working with groups of providers, both medical teams as well as a specific midwifery team. And I think there's kind of two things to balance in terms of the work from the perspective of groups and as individual providers. Both of those things are kind of grounded in two principles, one of communication and the other in terms of approaching communication in maternity care, specifically from the lens of family formation and transitions in identity. One of the things that the momentum of medical systems often does with maternity care is initiate the work from the perspective of disease or medical processes or pathology. The experience of many people is one of how am I building my family and who is it that I become with this transition in place and in context with others. And so part of doing respectful work comes from recognizing the perspective of what this means for families and where they live and how they live in the context around them. As a clinician, a lot of the work has less to do with what we're trained in certification programs and in diagnostic methodologies and care planning, and a lot more to do with, frankly, one of the things that we've spent less time on over the years that we've built a system of medical care, and that's communication. Some of the principles that often can be helpful are remembering this piece around family formation and making sure that we invite family and friends to participate in the encounter and in the planning of the experience. And with that, making sure that we have adequate time and aren't rushed. Simple things like, and this has become more common that people recognize, sitting down and starting the interaction with a question around expectations or goals for the conversation that the individual brings into the time. I want to acknowledge, having said that I think one of the systems things that we all need to pay more attention to, and as a provider, one of the things I advocate around a lot is that to provide the kind of time that respectful and robust communication deserves, we don't often have with our patients because of the pressures to see numbers and to generate volume. So I think that's something that is a core principle where we certainly have a lot of opportunity for growth. Listening more and talking less is a big part of moving this work forward. And as part of that, listening and sort of inquiring as specifically as we can in ways that help us explore individuals' understandings of their healthcare needs and of the reasons that they're there to engage with us. And as part of that, as we seek to understand perspectives, to also then provide additional information and to ensure that beliefs are grounded in as much of the evidence that we can offer, while also recognizing that evidence itself comes from a particular perspective, and being okay with the fact that what we believe to be true and important may not be shared by the individuals that we're working with. I think inherent with that is expecting and responding to emotion that will arise as we talk about care and about next steps. And that's a very difficult thing sometimes for providers to do because of, Lily did such a beautiful job of talking about the dynamics of power within these encounters. Eliciting values and goals is, somewhat inherent in these principles, but they're really important to take time to try to explicitly elicit before moving the conversation to the next step around decision making. I think another piece before moving into decision making in terms of care management is also just taking the time to pause and say, confirm understanding. Did I get this right? As I was listening. And then finally, just making recommendations that align with the individual's goals and values. I think a principle that is really important with that goes back to what Lily framed so well for us, which is power. And as we make recommendations and we think about the individual's goals and how we align ourselves within the time that we have with patients, is making sure that we recognize the systems of oppression that individual person is grappling with, and being aware that there are multiple systems of oppression that people grapple with, and trying to do the hard work of being responsive to those various layers and multiple perspectives of oppression that people need to hold in their own lives, so that we can try to modify and respond to them as best we can. One of the things that I think Dr. Auguste alluded to here is that as providers, we do bring that one-to-one experience and that individual encounter with folks. We also, particularly in obstetrics, work as groups. And I say particularly in obstetrics just because we are a 24/7 operation. And unfortunately, we can't be available 24/7 as much as we might want to sometimes, because continuity is incredibly important, but challenging to provide when babies will decide to come at all hours any day. So we do need to also think about how to create awareness and teams that work well together around these principles. And one of the things that I've found helpful in terms of working with the teams that I'm involved with is based around an acronym called CHANGE, and developed by two people in our local community who do some fabulous work around health equity. Dr. Wesley and King, Christopher King is at Georgetown, and Delia Wesley is with Mathematica. And they developed this acronym CHANGE, which I try to always bring with me to conversations with groups of providers, which is continually challenging our own thinking about what we've been taught as right, and what we've been taught as the momentum and the purpose of what we're doing within healthcare. Be humble. And again, thank you, Lily. You did, there's not a lot more that I could add to the beautiful job you did around talking about that and what it means in the settings where we work. Being aware of how we impact the surrounding and the individuals with us. A really critical piece is normalizing our own behavior and our behavior as a team to continually work to prevent bias. The things that we need to do to help ourselves and each other recognize and respond to our bias. In settings, one of the things that's really critical about that is that when we're in settings that are high pressured, where we're being asked to hold multiple pieces of information, especially quickly in our minds and in our encounters and interactions with others, that's when we're most likely to act with bias and act in behaviors and in ways that we're taught that reflect these systems of oppression that we need to disrupt. And so as teams and as systems, one of the most important things that we can continually work on, I think, is how do we create these settings within healthcare where we minimize that pace, that momentum, that sort of quickness and trying to hold so much in our minds about the tasks that takes us away from being able to grapple with the complexity of the context. A commitment to continue to grow in our own work and recognize that this is a lifelong and continual process. It's not a course, it's not a training. And then also making a commitment to do what clearly everyone here today is doing, which is to continually show up, to educate and engage around these topics. It took hundreds of years to create a system where we operate as if it were normal in ways that hurt one another. And so it's going to take a lot of time and a continual commitment to being able to break down those systems that we've normalized. So I'll hold there. Again, looking forward to questions and talking more about these things. And I think Dr. Auguste, you're going to share next.
Sure. Thanks, Loral. Hi, everyone. I'm Tamika Auguste. I'm the chair of OBGYN at MedStar Washington Hospital Center. And I want to give you my perspective. We've heard from, frontline, accounts and perspectives and more of a group dynamic. And, in my role, I'm in charge of a whole department. I'm in charge of upwards of 50 providers and how they touch patients on every aspect. I work very closely with our nursing leadership here. And I think it's very important that in healthcare organizations or hospitals, there's a lot that can be done at all of these different levels. It has to be done at all of these different levels in collaboration. This work around equitable healthcare is individual, but it cannot be just a responsibility of one. It has to be the responsibility of the masses and of those that have, again, we keep coming back to this word power, or those that are leading. It has to be that responsibility. So from my point of view in terms of departments, when I have patients that come to this department, I want them to know that they're getting the best care possible. And how do I do that around respectful and anti-racist care? Well, one, we need to set the expectations and the culture here within the department. And this is very purposeful, very clear. It is not implied. It is long gone are the days where we are talking about, right, we all give respectful care, right? Yep, sure. No, it is, we need to listen, and we need to act this way. And if we're not, then this is how we change it. We have to talk about this. We have to incorporate this, the way we take care of patients, this, and I'm sorry, but I hate to say this new way, because what has been done in the past has not been right? Like we have to change our ways. We have to change, listening to what Lily and Loral said is we have to change the ways we interact with our patients. So we have to incorporate this learning, this relearning. I'll give us the benefit of the doubt that we are good people at the core, and we have to relearn how this is done. But we have to be very purposeful about it. We would like to think that this is innate and that we treat everyone the same way. I think history shows that's not the case. So it is my responsibility then to educate the people that are here, and in terms of educating the right things to do. And again, it's not going to be implied, oh, this is a good way. No, this is how you deliver anti-racist care, and be very specific about it. I need to incorporate, we have folks that have great ideas, great resources, and then I want to reward those for bringing that forward, right? So in evaluations, in things that may, promote someone is, what work have you done around the space of anti-racism? I'm going to put a value to the work that's being done around that. Two, we have to supply resources to folks so that they can improve themselves and better themselves in the way they take care of patients. So those resources, they come from various places. Like Loral mentioned, it's not one course and you're one and done. This is ongoing lifelong learning. These resources around this learning, they come from local and city resources, our state officials for Maryland and Virginia, our city officials here in DC. Let's utilize that. We are a collaboration. We have to work together on that. There are wonderful resources, and let's use it. We have professional organizations, both for the medical and both for midwifery and both for nursing. Let's bring this all together, because these are all the touch points that our patients see. Whether you are a physician, a midwife, a nurse practitioner, a physician assistant, a nurse, a medical student, we all have resources, and they're all excellent resources for us to use together. I have to be able to give my folks, our frontline folks, time and availability to learn, to take it in, to change behavior. That has to be made available to them. There has to be time for engagement around this. Yes, Loral mentioned there's times when we have to see X amount of patients. We have to do this. But if we're really going to make a difference and deliver respectful and anti-racist care, we have to make time to make sure that we're doing so. And we have to learn from others. Gone are the days where, the doctor knows, the doctor says this, and that's what it is. Particularly in this area, we have to learn from everyone. And that brings me to my third point about listening and learning to our patients and our community. We have to listen. Lily has mentioned listening. Loral has mentioned listening. I think that is the most important thing. From my standpoint, when I unfortunately may get a complaint or concern from a patient, every single one is addressed. Every single one I listen to, because I will learn something from that patient. I will then have the responsibility to go and teach what I learned to the rest of the faculty and the associates here. That's how a department leads in this area, because you don't want to say, it's another one of those kind of complaints. Nope. You can learn something from every single one, but I have to take the time to listen. We need to engage our community partners here. Long ago, it's no longer the education is coming from the one with the most letters or the one that has, all of this learning. Nope. I have to learn from those that have the experience, the ones that are doing the work. And sometimes that's not the most senior person in the room. Sometimes that's not the academician in the room. Sometimes that is my neighbor next door. And so learning from our community and from our activists and our advocates that are in the community, bringing them here in different ways, small group discussions, larger grand round discussions, but we need to learn from them. And we have to talk about our errors and what we're not doing well. Got to call it out. I'm going to call it out. I'll share with you that some members of other departments and divisions may say, you guys talk about this all the time. Like, you're obsessed about it. I was a little taken aback, and I didn't know quite how to take it. And I was like, yeah, we're going to talk about it all the time, because this is what we have to address. It is in everything that we do. And so, yeah, I'm going to bring it up, and I'm not going to be scared to say, did she not get her epidural and you give the other woman the epidural first? Why? Was it because you think she could handle the pain because she's Black? Like, I've said those words. And so we have to call it out. That's my responsibility as chair of a department, and other leaders of organizations. That is the responsibility that you have to have. I hope my perspective was a little bit helpful and just kind of see what work is being done from this level. And I want to turn over to Angela now, who's going to give it even from a larger level.
Thank you, Tamika. Thank you, Loral. Thank you, Lily. This has been fantastic. And I want to make sure we have time to have a chat with our audience. So I'll keep my remarks very brief. I want to start by talking about a new talk that I'm finding that I need to have. So as background of me, Vice President for Healthcare Delivery Research at MedStar Health. So I have this funky blend of being an operational leader and a researcher. I'm also the executive leader of Safe Baby, Safe Moms. And despite all of that, I am still a Black woman. I still have to grapple. I'm a mother. I'm a wife of a Black man, a mother of a Black son. And I live in a society that makes judgments about me because of the way that I look. I'm also a faith-based leader. And so for me, it's extremely important that we fix the system that we have to function in as we're talking about these types of issues. So here's the talk. Everybody is now probably aware that we have a talk as African-American parents that we now have to give to our children about interactions with the police. Well, there's a talk that I'm finding myself having to give to members of the community who have to interface with the healthcare system. And this happened actually as recent as yesterday with a friend who has a medical emergency with her 6-month-old baby and has to navigate a very complex healthcare system to ensure that her baby stays safe. And so here's the redacted conversation. It's extremely important that you feel empowered to be his advocate. This is important before the pandemic and extra important because healthcare staff everywhere are exhausted and overwhelmed. You must keep him safe. Ask questions. No question is too dumb to ask. Understand his care plan, how they will treat him, why they are treating him that way. Take notes because they might say something you don't understand, and send those notes to me or any other healthcare provider that you trust. The squeaky wheel gets the best care here. And as a patient safety health equity researcher, we've seen over and over and over again that there's biases in the healthcare system. And unfortunately, these are the types of talks that we have to have. Why the talk? Well, I remember when I was a teenage mother seeing a behavioral health provider having all kinds of assumptions made about me that affected my healthcare. I remember when I was having a heart emergency and rushed myself to the emergency room with my 6-year-old son being accused of being a bad mom because I drove to the emergency room and I was having a heart emergency. That wasn't really great. I also remember the time where I knew my body was in pain, but nobody would listen to me in the emergency room. And because my village told me to keep pushing, they found that I had a bowel obstruction and they were going to send me home and I could have died. I remember that. And I also remember how now I use my title of doctor. I'm cautious about the way that I appear because I know assumptions are made about me. So how do we change it as a system? And what are the things that we're trying to do? My colleagues have highlighted tons of these things, but I want to bring some of those out. One, we have to have a commitment at the highest levels of leadership in every healthcare organization that we must dismantle the systemic racism. It has to start there. You see, my colleagues, they are committed themselves as individual providers, but without the support at the highest levels of leadership, it won't happen. The next thing we have to do is that we have to acknowledge racism and discrimination as a social determinant of health. Social determinants of health in the last few years have become popular to talk about: poverty, education, transportation, housing, et cetera. But people are still pretty hesitant to call out the experience, the daily experience that Lily did a wonderful job highlighting of racism and discrimination as one of those social determinants of health. We do have to engage and roll out system-wide implicit bias training to make our providers and other care team members, staff, et cetera, aware of what it is, aware of their biases, et cetera. That's super important. We also have to go beyond that. And I'll highlight a comment that came through on the app to really underscore this. So thank you to the person who submitted the comment. It says, I recently discussed that despite the absence or presence of bias of inequitable treatment in healthcare or healthcare access, the very real and present face of the issue is the fear of it itself. The fear of bias or inequity in existing without clear or secure knowledge of it. I am not individually informed or knowledgeable or trained enough to determine whether a standard or a practice of care is appropriate or not. I cannot necessarily ascertain whether the response is appropriate medicine as taught and recommended by medicinal systems, or whether the protocol and decision-making is appropriate and consistent with that offered and administered to other identities. But I do fear that it's not, thus leading to the potential of distrust in healthcare relationships, not necessarily or even exclusively with direct providers, but the entire network of infrastructure that facilitates and operates the gate of access to this very care, regardless of the identity of such individuals, man, woman, color, or any particular identity. How can I not live afraid to protect my health? That gets into what Lily and Loral both highlighted, is the role of trauma-informed care. We have to understand how people are showing up to receive the care and be humble to seek to understand, to seek to listen to origin stories and understand how that affects their interactions with the providers, they're taking up care plans or not, and how they interact with the entire healthcare system. Importantly, and this is my bias, but I'll stand on it, is that we have to have evidence-informed research care. What does that mean? It's beyond evidence-based practices. It's also measuring it. It's stratifying outcomes by race, ethnicity, language, gender identity, and other measures of equity. We have to begin to measure these differences that we see in our system, to hold ourselves accountable to when it's happening so we can address it. We need to have equity dashboards. As we measure ourselves by performance, we stratify that by race. I know Dr. Auguste is beginning to do that as the chair in her department, but it has to be done system-wide. We have to measure our performance by key equity indicators. And most importantly, a lot of the data that we collect as a healthcare system, it's the voice of the provider. It's quantitative. It doesn't include the voice of the very people we're serving. We have to find systematic ways to collect the voice and incorporate the voice of those people, of the folks that we serve. We hear story after story after story in the maternal space of a birthing individual saying, something was wrong and I told them, but they didn't listen. Or unfortunately, the situation where the family says he or she said something was wrong, but they didn't listen and they're no longer here. How can we begin to incorporate the voice into the care practice? One of the examples of many of the things that I've highlighted is the Safe Baby, Safe Moms initiative funded by the Clark Foundation, where we integrate many models of care. We have implicit bias training, trauma-informed care, measuring by equity, and many other things. But again, that's one initiative. The healthcare system needs to do that overall. We also need to find systemic solutions. I always say, okay, we can do all the implicit bias training we want to, but if somebody is dedicated to being racist, sexist, and discriminatory, how do we still protect the person for whom they're providing that care? And so we have to find systemic ways to ensure that people are getting the care that they need in an equitable way. We have to change reimbursement models as well. Loral talked about this, having the time necessary to have the proper communication necessary with our patients. And to do that, reimbursement needs to change to align with that. We need to change our incentives and penalties based on these equity dashboards. And we need to remove the variability across different healthcare systems when it comes to resources. Those in the community shouldn't be penalized because the healthcare system they're going to has fewer resources than the healthcare system across the tracks. And so we have to better resource those as well. So those are the things from a system perspective that I was hoping to bring together and share. Hopefully it highlighted many of the things that my colleagues already spoke to. So with the last few minutes, we do have some questions that have come in, and I'm just gonna look at them in the chat. All right. Got it. So we have a question from Charmise Littles. It says, may you all speak towards effective ways that families and other healthcare workers can report and hold healthcare workers accountable for providing disrespectful and racist care. I find that it's not easy to do or transparent to families and the community. I'll start, but I'll ask my colleagues to chime in as well. As someone who works very closely with our quality and safety team, there are many channels, and to your point about transparency, I think we can all do a better job across the healthcare landscape. But there are, call your local healthcare system and say, I want to forge a complaint. Everybody has a patient advocate or patient's complaint hotline and that's what I did. When I had that emergency experience, I called to make sure that they received that feedback, and the nurse involved in shaming me for what I did. It was important to me for her to get the feedback. And they gave her that feedback. And so it's super, super important. We can do better on the transparency of that. It needs to be plastered all over the rooms, all over the hallways on how patients and families can do that. Don't know if any of my other colleagues have suggestions as well.
I agree. And I think that we, as a community, as patients, because I think unfortunately we've all been patients, that we should have the expectation that we have follow-up from when we file a complaint. That's why it's so important to me to answer every single one of those, to speak to the patient involved and to listen to them. So I think that, as patients, we have to empower ourselves and each other to speak up about the concerns and to make demands that we speak to someone about it and we have follow-up about it, and not just let it go out in the air and we don't know what happens to it. And I think that is the voice that we all need to get. We have to empower each other and ourselves as patients in order to do.
Thank you, Tamika. We've got a few questions in here, and they're all great questions, so I'm gonna keep running through them. So this one is from Naima Mohammed. I've done research in this area. What I heard most from women is the lack of being heard and understood. Their pain or concern was real. How can we change this? I'm gonna give this one to Lily because she's at the bedside where a lot of these concerns are heard. Lily?
Well, we do a lot of work in our department partnering with our anesthesia colleagues who are there 24/7. And we, like Tamika Auguste was talking about all the time, we talk about this. We actually, because we talk about it so much, one of our nurse colleagues, just as a chat when a new anesthesia provider came on board, said, oh my God, I know, this is so, welcome to the field. We're so happy to have you. I'm so energized to hear what your perspective is on how we can dismantle, racist care and, restructure what we do. And he was like, why are you bringing this up? And she was like, we all talk about this all the time. This is the culture of our unit. And so part of it is working among disciplines to be able to make sure that our anesthesia colleagues who may not be getting that training, get that training. We need to be training on every level. I mean, I'm coming from an education perspective too. So, we need to talk about pain as a concept. In curricula, it needs to be embedded in the curriculum of everything before they get to nursing school, when they're in whatever professional school, whether it's nursing, medical school, midwifery school. When we onboard them, I'm currently onboarding our new nursing colleagues. I'm talking about it all the time. And then we need to reinforce it. And our management colleagues must be a part of this too. Because if we are not partnering with our administrative colleagues here to treat pain, for instance, or any of the other issues that we're talking about, then we're powerless to be able to partner with our patients to care for them. And now we're alienated from our means of caring production as clinicians. And so I think that we need to hold ourselves and each other accountable very actively, in a very active way, and partner not only with our anesthesia colleagues, but really just hold each other accountable. We huddle every 3 hours. So I think that we're always trying to hopefully hold ourselves to that, but I don't know if anyone else has suggestions.
So holding ourselves accountable, embedding it in the education practices, that speaks to a couple of other questions I'm going to group together. One from Jasmine Leonard. Yesterday, there was a mention of reorienting the conversation from cultural competence to structural competence. That seems to be some of the same messaging from this panel as well. Are there any resources or work that you can speak to that explore shifting the narrative from cultural competence to humility and understanding the structures at play? And then the other one I want to just kind of tie that to is from Colleen Harner. How can we address this systemically, educating not just individual providers and practices, but facilities and nursing staff, as well as providing education for individuals on how to recognize bias and advocate for themselves? And so, Lily, you talked a lot about the need for this to start in education, in the education space. So that speaks a lot to the structural piece of it. But I also, because healthcare systems don't just include providers and clinicians, but a whole bunch of other staff that can contribute to adverse care experiences laced with bias and discrimination. It also speaks to systematically, as a system, providing these types of educations and finding the structural ways that we can embed the voice of the patients in there. That gets to the first question, structural ways. So it's not just the person who feels empowered to say something that's capturing the voice, that's calling back to complain, but we're actively seeking every single patient's voice. That needs to be part of our structure, our new way of delivering care. Tamika or Loral, any thoughts on these questions?
So I have a couple of things. One, thank you so much. These are such great questions. So I can speak a little bit to this idea of, how does this come into an actual setting, just by sharing some of what we've done over the last year in our OBGYN center, which is I worked specifically to try to find something that was more practice-based for a specific team. And unfortunately, I don't have a resource to share because I didn't find one. I partnered with a health equity scientist and a social worker who's done a lot of work with trauma-informed practice, and we've been developing our own curriculum. And I'm fortunate to work for Dr. Auguste, so we were able to dedicate a half a day a month, actually, to take the entire team out of direct patient care for an afternoon so that we could spend time together from sort of front desk to provider. Because as Angela mentioned, a part of the systems competence that you all are mentioning is making sure that we do things like this to bring a system together so that we start to think about these things collectively from multiple perspectives. And I think it's critical to moving us forward because for me, so far, it's I think it's one of our few options for really trying to tackle head on the multiple systems of oppression that we've built into the healthcare system that we have. This is definitely a structural competence issue, in my opinion. Our system was built by design not to treat everyone equally, not to care about everyone equally. And that is not okay. The momentum of our system, unfortunately, is still very much in that direction. So I think it's, it's going to be a process for us to find those resources and develop those resources. Our team has tried to, in these sessions, start to break down and work together on dealing with some of the environmental pieces that we know contribute to creating environments where people are more likely to act through violence and to lean back into those oppressive systems as they interact and do their work. I will make a shameless plug for anyone. I saw Kimberly Sharp's question there. And if you are interested in making sure that your voice is welcomed and elevated when you see these things and try to engage in this systems change, I have 2 positions open. We are actively looking for a nurse navigator, and we are actively looking for a social worker to be part of this work at the hospital. So my email is really easy. It's laurel.patchen@MedStar. And if you are interested in this work, I would love to engage in a conversation. We certainly don't have all the answers, but we are a team that is really interested in working together to grow and move towards solutions.
Thank you, Loral. And thanks for calling out that question. I was actually going to call out hers and Tiara's next. So Tiara Fletcher says, how can I not live afraid to protect my health? And related from Kimberly Sharp, how can someone like me, as a healthcare provider of color, begins having these conversations without being labeled as the angry Black woman or nurse? And so and we only have a few minutes left in this session. So I just want to kind of address that. Number one, it's system solutions. So love how Loral just talked about how she's hiring for a few key positions. If we can have more positions that are dedicated and embedded in the system to walk alongside the patients, to have lived experiences, relatable experiences, to help be the voice of patients experiencing the healthcare system, because not everybody is going to feel empowered to speak up, but they still should. That doesn't mean that they don't deserve equitable care. And so the more we can have these advocates embedded in multiple ways within the system, that's a system solution to it. Unfortunately, to Kimberly's question, right now, most times it's an individual responsibility of how do I get creative about using my voice and not coming off as the angry Black woman, whether that's in a position of being a provider, as Kimberly is, as a nurse, as a leader, or as the patient themselves. I've experienced all of those except the provider piece, and it's a dance. It's a dance of how to be gentle, how to be forceful, how to put something in such a way, and just simply sometimes you just have to fight because it's just that critical. And so I don't know that there's a best recipe at the individual perspective. And that's why these system solutions are so critical, because we shouldn't have to wear that burden. Because to Lily's earlier point, to do that day after day after day after day weathers us, and it affects our health long term. Tamika.
Yeah, I just wanted to speak to that too. I hear it, I understand it, and I think a good point, in addition to what Angela said, is that we need allies. We need allies of all different colors, genders, and backgrounds in this discussion. So, this is not a Black thing. I say that all the time. I'll say it again. This is not a Black thing. This is a people thing in terms of treating everyone respectful. So I think that, so to particularly answer Kimberly is, get a partner, get someone that understands and has a similar point of view, and then work together on the messaging and how you respond to that person that says something inappropriate, something snarky, and so that you don't come across as being angry. But you know what? Sometimes you have to do it. I think the mission is most important here. So I'll stop there.
I think we can also learn a lot from our partners in the doula community. Mama Toto with their sliding scale doula services. My gosh, I've learned so much from that community about language and advocating. And, I think there are some pockets out there for partnering with people and then encouraging those of us who maybe didn't consider those professions to get in those professions. More midwives of color, more lactation consultants of color, more non-binary doulas, whatever has happened. We need to just infiltrate. We need to infiltrate. And then once we're in, we need to learn, and we need to teach another person, and we need to normalize this. We need to embed it in the curriculum so much that people don't even think about it. So like, for instance, we, in the current simulation videos we're doing, we have this really beautiful piece where we create a really complex portrait of someone's partner who is a Black man who's very worried about his partner dying. And it's in there so that we can debrief it. We intentionally put it in there so that someone can say, just in case someone's going to say, why is he acting that way? So that we could debrief it, unpack it, address it before they get back to that bedside. We do that already in nursing schools. We should do it more. We should do it more in all of our schools. We should do it at our conferences. We should be embedding all of this stuff so that it is as basic as hand washing. Because recall that hand washing, Ignaz Semmelweis was ridiculed for suggesting that we wash our hands before we touch patients. And now it's something that we take for granted. This is something that we can do. I think we can do this, but we must embed it in every piece of every interaction.
Thank you, Lily, very, very much. As you can see, we're all very passionate about this, and we can probably continue to answer many questions and go on and on. We hope this was helpful, informative, and a start of the conversation about what to do. We know there's a problem there. We know that we've been talking about that. Now we have to start talking about solutions, and hopefully we've gotten the tip of the iceberg here in terms of talking about what can be done, what should be done, and what is being done locally in our community here in Washington, D.C. So with that, I wanted to thank the rest of the panelists. We're happy to answer any questions offline on email, and we hope that everyone has a very safe and happy day. Thank you very much for attending.